In case of insomnia or difficulty sleeping, using our mnemonic old cards, we note the onset, or when did this start. For duration, we're interested in knowing if this is occurring constantly, every night, or is it more intermittent, for example, on a Sunday night before the school or work week, or after a night shift or a flight. If it is, we'd like to note the frequency. How many nights per week is this happening? Also, we can note the progression. Does it appear to be occurring on more nights? To characterize the insomnia, we'd like to note the sleep cycle, and we're going to use our mnemonic or technique of pre, present, and post for our line of questioning, as we'll see below. Aggravating and alleviating factors, and treatments tried, such as melatonin. And melatonin does work. For those like me with trouble falling asleep, try it with the link below. The 10 milligram knocks me out. And if there are none, we'd include that as well in our note to show that we asked. In the pre-sleep, we're interested to know the bedtime routine. For example, is there excessive screen use or TV use? And then the time that we're going to bed, the time in between from when we go to bed to when we actually fall asleep. All of those can be noted down. In the present sleep, we're interested in knowing how many times do you wake up from your sleep, and then what time do you usually awaken from sleep, and then how many hours per night are you actually sleeping. And in post-sleep, we'd like to know if you wake up feeling refreshed, if there's a daytime sleepiness or need to nap, and how has it affected you. For all cases, we should order a CBC, serum electrolytes, TSH and T4, EKG, and urine toxicology. In hyperthyroidism, our supporting points will include insomnia, an anxiety or increase of worry, weight loss, heat intolerance, palpitations, diarrhea, tremor, all symptoms that we would note from our review of symptoms, and as we'll see in our physical exam, increased deep tendon reflexes. In caffeine use, we'll see early insomnia or difficulty falling asleep from the caffeine, a nighttime awakenings, palpitations, and a history of caffeine use. In drug use, such as from cocaine or amphetamines, among others, we'll again see early insomnia, nighttime awakenings, palpitations, and a history of drug use. Circadian rhythm disorder can be written alone as its own differential, but for completeness can be further broken down into intrinsic or extrinsic etiologies. In intrinsic, we see delayed sleep-wake disorder, such as a typical night owl, or an advanced sleep-wake disorder. And in extrinsic, causes can be due to shift work disorder or jet lag disorder. In obstructive sleep apnea, we'll see insomnia, and we could use the mnemonic stopping for snoring, daytime tiredness, observed periods of apnea choking, a high blood pressure, a BMI greater than 35, an age greater than 50, an increased neck size or neck girth, and a male gender. And we'll add to our workup a polysomnography. In general anxiety disorder, we'll see early insomnia or difficulty falling asleep from the increase of worry. And it can be further broken down into psychological versus physical symptoms. In psychological, we could see this increase of anxiety or worry. The patient can be irritable and decreased concentration throughout the day, affecting their work or school. And physical symptoms can include palpitations, sweating, a tremor, or increase in respiratory rate or heart rate. And we'll let the G in generalized anxiety disorder cue us in to remember it's a duration for 6 months. And we'll add a GAD-7 questionnaire. In major depressive disorder, we'll use the mnemonic SIGI caps for sleep, decreased interest, guilt, decreased energy, decreased concentration, or appetite changes or weight changes. Typical presentation is a decrease in appetite and decrease in weight, or it can be an atypical presentation with an increase of weight, psychomotor agitation or restlessness, or retardation, restfulness, suicide ideation, and a duration greater than 2 weeks. The SIGI CAPS mnemonic are 8 criteria, and the 9th criteria being a depressed mood. One of the 5 criteria need to include a decreased interest or depressed mood, and we'll add a PHQ-9 or the Beck Depression Inventory. In adjustment disorder, we'll see insomnia with a stressor such as a job loss within 3 months. And finally, in post-traumatic stress disorder, we'll see insomnia, a trauma, nightmares, flashbacks, avoidance of the trauma stimuli, a negative mood, and a duration greater than 1 month. Okay, we'll start our abdominal exam with a hand sanitizer, and we want to ask our SP if we have permission to examine you. Okay, and we'll start with the hint exam. We'll look into his eyes if we're going to be concerned about jaundice in an abdominal case, so we'll make a comment that there's no scleral icterus, and look down, please. Okay, we'll move on to the oral pharynx, so we'll use a tongue depressor here. The key thing to do is you don't want to add too much pressure for the SP, so just very lightly you can press down, ask them to please stick out your tongue. Okay, and we'll comment that we don't see any lesions. You could visualize the thyroid and see if there's any visible lesions, and a good tip is to offer the patients a glass of water to see if it will help them swallowing. Would you like a glass of water to help you swallowing? Okay, so the next thing we could do is then feel for the thyroid, so you ask them to take a swallow. Okay, and we don't feel any masses, and we could do one on one side at a time. And then with the thyroid, we're going to introduce this mnemonic that we'll see again with the MSK exam, which is MSRP, and manufacturer suggested retail price. And so this mnemonic will help guide you, along with the thyroid exam, the other components to look or to check for thyroid issues. So we'll start with the M, which is motor. So ask the patient to please make a muscle, and we'll test his motor strength. So he has 5 out of 5 flexion and 5 out of 5 extension. No real need for sensation like a neuro exam for the thyroid, but we're used this opportunity to let it hold as a placeholder for cyanosis and delayed cap refill. So we'll go ahead and look at his fingernails, and you don't see any cyanosis. And we could press on his fingers, and we don't see any delayed cap refill. We'll look at his reflexes. So we're going to look at his biceps reflex. We'll place our thumb on his biceps tendon, and this would, his normal reflex would produce a 2+ response. Okay, and if we were concerned for a case of B12 or hyperreflexia, he would have a 3+ response. Okay, you would see that. Now we could assess his radial pulses as well. So we could do 1 at a time, 2 at a time if you're more comfortable, and we'll verbalize that it's a 2+ pulse, regular rate and rhythm. After we completed the MSRP for his upper extremity, we can now move down to his lower extremity, and we could do the same thing. His motor response on his lower extremity, so I'll go ahead and kick out for me. So he has a 5 out of 5, and then bend in, so a 5 out of 5. And now for sensation, for his lower extremity, we would ask him to close your eye, please. Close your eyes, and do you feel this equally? We could instruct him to relax, and we'll do a patellar reflex. So a normal patellar reflex would be like 2+, and then if we were concerned like hyperreflexia or B12, we would get a hyperreflexive response. So just relax, and you would see something like this. And we can continue to demonstrate with the tap on his Achilles tendon. So we'd start right here, and we would get a normal reflex, and if this was a case of B12 and we were concerned about hyperreflexia, he would give us a dramatic response. Okay, you feel that. We're going to check his posterior tibial pulse. So it will be behind the medial malleoli. We can go ahead and do 1 at a time, or if you're a little more comfortable, you could do 2 at a time. Just comment that it's 2+ regular rate and rhythm. And now once we're finished down there, it's always a good idea to hand sanitize again. So while he's still sitting up to the cardio exam to get that out of the way. So the best way to do this here is, again, to lower the gown slightly and to ask them to please sit and hold it like this. This will protect them and keep them covered up. We want to verbalize that we don't see any visible lesions in the anterior chest, no visible lesions to the posterior chest. We'll go ahead and palpate and see if he has any chest tenderness. So please let me know. Okay, we'll do the same thing on the back. The next thing we can do is auscultate for his heart sound, and so we'll use the mnemonic apartment M225A, and we'll listen first in his right intercostal for the aortic, and we'll go over to the left for the pulmonic, and then we'll go to the tricuspid. And now for mitral, if this was a female, a good tip is to ask them to please lift up your upper breast. You could comment that we hear an audible S1, S2, regular rate and rhythm, no audible S3s, S4s, or murmurs, rubs, and gallops. Once we completed the cardio, we could transition nicely to the pulm exam while he's still sitting up, and so we could go ahead and percuss. We'll start above his clavicle, comparing left to right. And we're going to go ahead and do the same thing on the back, 3 spots. We could auscultate again, and we'll start above the clavicle. We're going to use the bell first. Please take it, and the instructions you want to give is please take a deep breath when you feel my stethoscope. Please take a deep breath in and out. Okay, compare left to right. the same thing on the back now. Okay, now we could verbalize again that it was cleared auscultation, no audible wheezing. Once we concluded the cardio and pulm exam, we could cover him up again. Now we can instruct him. I'm going to now lie you down to do the abdominal exam. Is that all right? Okay, so we want to help them down. And you don't want to forget to extend the legs for the leg rest. Now you could rest your legs. For the abdominal exam, they'll have a gown here, and you want to move it up all the way to their pelvis, and then you want to ask permission to take it up. We want to do the same step again. We want to first verbalize that we see no visible lesions. First, ask if he has any pain anywhere. Okay, now we could verbalize that we heard normal active bowel sounds, and then we'll go ahead and percuss in the 4 quadrants. Okay, and we want to ask them if they have any pain first. You want to avoid those areas. So do you have any pain anywhere? No. Okay, so we'll start in the lower quadrant here, and we'll do superficial first, just with one hand. We could make good eye contact with the SP to see if they have any pain or if they wince. Painful at all? Okay, now we'll go ahead and do deep, and for that we could just signal we're going to put one hand on top of the other. Any pain at all? Okay, so no pain. And then to conclude, once we complete a deep palpation, we want to go ahead and check for hepatomegaly. So the best way to do this is to place your hand under the border of his liver. You want to instruct the patient to please breathe in. And then as he breathes out, you can breathe out now. You want to go all the way up into the lower rib cage, and as long as you don't feel the liver extending below, you can verbalize that there was no hepatomegaly. And you can do the same thing for the spleen. So again, please breathe in. And now please breathe out. Okay, and you can feel the lower left rib, and there was no spleen coming down. And now that concludes the abdominal exam, so you could help cover them again. And then sit them up. Could I help sit you up? Okay. And then you just want to ask them if they have any questions for you.
Yeah, no.